The premise of this debate is that standard EVAR can be used in most challenging necks, and I am for the motion. I will argue that EVAR is an effective treatment in most patients, and in recent years we've seen a significant increase in technology associated with improvements in outcome. Graft design and techniques have evolved to tackle the short-term issue of sealing and long-term issues of migration and type 1 endoleak. I will argue that EVAR is appropriate, our patients are not fit, and extending long-term solution is not always needed. And lastly, with COVID-19 around us, there's a reason to treat whoever we can under local anaesthetic with a shorter hospital stay.
Colin and I are going to debate the motion standard EVAR can be used in most challenging necks, and I am, of course, against this motion. It is a very pertinent question, and I think over the last 5 years we've now got quite a lot of evidence to show that the motion doesn't work. You could argue, if you were being impertinent, that you could use standard EVAR, but we now know it doesn't actually work, so it would be wrong to do so. I think most challenging necks means the majority of challenging necks rather than the most challenging necks, but either way, we've now got a lot of evidence to show that standard EVAR doesn't work, or certainly doesn't work in either the short, mid, or long term. Even though we as a vascular community would love it if it did work, the sad and painful truth is that we know that it doesn't work in quite a number of patients.
In the aortic aneurysm controversies programme, in my corner, watching my back with this debate, is the excellent Will Jordan, who's going to talk about the longer term results of the anchor registry and the effectiveness of endo anchors. Results that underline the principle that technology is improving rapidly to treat challenging aneurysm necks. This is important for the global vascular community because we as a group treat elderly comorbid patients who would significantly benefit from endovascular approaches to treatment of aneurysms. But there are worries about long-term durability of this procedure. Even though we work together in the same institution, we seem to have very different approaches to this question, and why we're debating was a real problem, but I can only assume that his waiting room is full of fit, young patients with aneurysms, and all the more comorbid elderly patients come to see me.
So this is a very important topic for the global vascular community. I think, worldwide, we have adopted the most minimally invasive technology, and that is what patients want, and that's what we want, because it is better for patients and it reduces their length of stay in hospital. It means their recovery is faster, and importantly, up front, their mortality is better. But, and it is an important but, that treatment has to work for them. And if that treatment fails, well, it's not a good treatment for them. I truly believe that one day the technology will be there to treat the most difficult aneurysm morphologies. But at the moment, using the current technology we have, that is just not the case. And I think why longer term it is crucial is that we have to adapt to the knowledge we've now got. And whereas perhaps 5 years ago there was a great deal of optimism that some of these newer treatments, which I no doubt Mr. Bicknell will talk about, were going to be efficacious, we now know that actually they're not so good. And we have to take that knowledge on board and adapt our practice now to suit the data we have. So we're very much looking forward to Charing Cross 2021. I think there's been a huge amount of work with this virtual platform, and I think it looks really exciting, and I'm very glad that we can still have robust debates about controversial topics, because that's what makes Charing Cross special, and this platform looks as if it will keep the integrity of the normal meeting, which hopefully come another year's time we'll be meeting face to face for 2022.